Vitrectomy for ROP. This video demonstrates the difficulties during vitrectomy for ROP surgery. The difficulty starts with the sclerotomies. The sclera is very elastic as compared to the adult retina, and due to the smaller eyeball and smaller palpebral fissure, there is minimal space for manipulation. The sclera is very elastic and the sclerotomies has to be very careful, as there are chances during sclerotomy, if you press more, you can perforate the eyeball or the retina through. The sclerotomy should be perpendicular, slowly in a screwing fashion. Additionally, a small scleral buccal band can be used to reduce the length of the sclerotomy. In stage 5 surgeries, 2-port vitrectomies should be done. An anterior side port is made for infusion. Lensectomy should be done through anterior port, and a 2-port vitrectomy can be done. So in lens sparing vitrectomy, standard 3-port vitrectomy, core vitrectomy is done. You have to be careful not to use lot of vacuum, as there can be anterior pull of the retina which can create retinal breaks which are not visible and create trouble in the future. So careful dissection of the vitreous, complete removal of the vitreous from the traction is important in ROP surgery. There is no necessity of inducing posterior vitreous detachment, or there is no need for PVT detachment in ROP surgeries. The aim is to remove the vitreous from the traction site and release the traction so the retina settles back in a period of time. So in lens sparing vitrectomies, once the vitreous is slowly removed, you have to be careful not to touch the retina or even not to touch the lens, as this creates, as soon as there is a lens touch, you have to do a lensectomy. Slowly and meticulously, all of the traction and membranes which are visible should be removed without avoiding any retinal traction, iatrogenic retinal traction and breaks. So once a thorough vitrectomy is done, complete laser should be done to the avascular retina, and usually a tamponade of air or gas is used. In extreme cases, silicone oil is used. In stage 5 cases, as previously mentioned, after the lensectomy through the anterior port, slow meticulously with the use of multiple instruments or accessories, membranes are released, anterior membranes are released, as you can see with the cutter, or scissors can be used to dissect the membranes and open the funnel so that the retina slowly goes back and settles over a period of time. Although stage 5 surgeries have a very poor outcome, but nowadays with the advancement of the instruments and minimal invasive surgeries, the outcomes have improved than the previous era. The retina can be seen unfolding and the vessels can be seen, and slowly the retina goes back. In such cases, a silicone oil tamponade can be used. So to conclude, vitrectomy for ROP is challenging. Careful sclerotomies should be made during surgery. There is no need for PVT induction, and you should avoid any lens or retinal touch. The most important part is parent counseling and post-operative therapy for the baby to have better outcomes. Thank you.